Good morning. I'm going to get things started right now, if everyone can sit down. We're starting a little late, and I have the great pleasure of doing a double introduction. It's exciting for me to have this opportunity to introduce two really extraordinary people because they've both been very instrumental in my career choices in medicine and have a lot to do with the trajectory of my own life. Today was meant to be the first annual Nair Honor Lecture in Pulmonary and Critical Care Medicine. Unfortunately, it is now the Sreedhar Nair Memorial Lecture due to Shree's untimely passing away over the weekend. So our first lecture is a lecture to honor his career rather than just to honor his activities. Many of the younger people in the audience have not had the privilege to know Dr. Nair. He was clearly one of the giants of pulmonary medicine. Shree seemed to be friends with everyone who has ever been famous in pulmonary, and he has certainly been the father of pulmonary and critical care medicine at Norwalk Hospital. He came to Norwalk in 1958, and with a group of 4 other physicians, 4 years after he set up practice, he founded the Norwalk Medical Group, which has been certainly an important force in our community. After that, he became the full-time chief of pulmonary and critical care medicine, and later became one of the first physicians in the United States to take the board certification exam in pulmonary medicine. I'm pretty sure he had number 4 on his certificate. And for the older ones in the audience who know him, Tom Petty was one of the other giants of medicine. He sat next to Tom, his lifelong friend, taking the pulmonary boards. He was also one of the first winners of the American Thoracic Society World Health Award in 2003. He built the pulmonary section based upon state-of-the-art technology and innovation, which was backed by an amazing skill at fundraising from a cadre of patients who absolutely adored him and would do anything for him. He was central to my own decision to come to Norwalk Hospital. And in fact, this was the first community hospital I ever set foot in before coming here to work. And the reason I came here was to a great extent because of Shree's reputation and what I knew it represented. 20 years ago, I took over the pulmonary section from him, and it was certainly something to work with. I could spend the rest of the hour telling stories about Shree. He was really amazing. He was an absolutely remarkable man. But I have to introduce today's speaker, who is no less remarkable on her own. Dr. Stover is the ultimate local girl. She grew up in Queens. She went to college in Queens. She went to medical school in Philadelphia and the Bronx. And she did her internship, residency, and fellowship at Harlem Hospital, Cornell Medical Center, and Albert Einstein Medical Center. So she's really one of us. She's from here. She's currently the professor of medicine at Cornell and chief of the pulmonary section at Memorial Sloan Kettering Cancer Center, where she has spent her entire career. Her many honors and accomplishments are really, I could be here the entire hour telling you about Diane as well. But I suspect she's most proud of her reputation as a master clinician, as a mentor to a generation of pulmonary fellows, and as an inspiration to everyone who ever came in contact with her. I count myself among that last group. When I was a resident at Cornell and a student, I was one of those awestruck students who saw Dr. Stover and was ultimately inspired to go into pulmonary medicine because of her. It's an incredible honor to have Diane to kick off this first Sreedhar Nair Memorial Lecture. I know Shree would have been absolutely delighted. He knew that she was going to be the speaker for this talk when he was still alive, and it really gave him a lot of pleasure to know Diane would be the person that was here. So I'm really happy to introduce my good friend, Diane Stover.
Thank you very much. It's really a pleasure to be here to meet with good old friends, and I emphasize good, not old, and to make new friends. Today, and also to be the first lecturer for Dr. Nair, I think we share a lot in common, particularly our interest in getting people not to start smoking, and if they do, to stop smoking. And today I'm going to talk about women and lung cancer and some of the questions involved with this and some of the controversies. Now, question I want to address is, are women more susceptible to develop lung cancer compared to men? And some of what I tell you is going to be fact, what everybody agrees with. Most of it is controversial. Some of it is contradictory. And I think I'm going to leave you with more questions than answers, and I think that's a good thing because this is an area that really needs a lot of research. I was going to talk a little bit about the history of tobacco in the world because it's very interesting, but I don't think I'll have time. And I wanted to talk a little bit about statistics and the differences between men and women for lung cancer, including some of the epidemiologic data, some of the molecular data, genetics, hormonal types of cancer that women get compared to men, the treatment, how it differs, and also mortality and survival. So since the 1950s, there's been an increase of 600% in the incidence of lung cancer among women. And how did we get to this epidemic, which is truly an epidemic? I'm going to skip this, but suffice it to say that by the 1800s, where there was very little smoking in Europe, by the 1800s, smoking had become acceptable in Europe. And something interesting, Juarez was touted to be the first European to smoke in Europe. And when he had his first cigarette, he actually was thought to be possessed by the devil because smoke was coming out of his nose, and he was not hospitalized, imprisoned. And after he came out of prison, smoking had taken up in Europe, and the competitive nature of it was looked at. It was seen as a big economic boost, and also for its recreational activities. However, in the United States at that time, in the early 1900s, smoking was frowned upon. However, a lot of chewing tobacco took place at that time, and when TB became a problem, it was felt that spitting out the tobacco may be a way of communicating TB. So that was kind of banned in the United States. At the same time, there was a mass production of cigarettes, and those cigarettes were sent to our troops in the world wars, and this was one of the big reasons that men started to smoke. And as the market became saturated for men, the tobacco industry started to hone in on women. And this is one of the most famous advertisements, Rosie the Riveter. And this is to show that women, if they could do a man's job, they could also smoke a man's cigarette. And here you see when you're doing a bang-up job, you want to bang up smoke. And in the background, you see buy war bonds, so there's a subliminal message here that this is also patriotic to smoke. And this was one of the first advertisements to show that smoking was associated with weight loss among women. And this feature has come through the 21st century. And it says here, to keep a slender figure, no one can deny, reach for a lucky instead of a sweet. And I just wanted to bring out the movies were a great impetus for women to start smoking. This is Bette Davis in one of the very famous movies that smoking was almost in every scene, where the male lead would light 2 cigarettes and give her one of them. And after this movie, a significant number of women started to smoke. And the movies nowadays are the same. They are getting our teenagers and children to be a great impetus to start smoking. They portray romanticism, sexiness, and glamour. In the 1960s, the Virginia Slims advertisement started a tremendous boost in women smoking. They touted the 5 S's, You can become slim, successful, sophisticated, sexy, and social. And the social aspect of smoking among women is quite large, particularly among college women. They look at smoking as a social event, and there's very little understanding that if they smoke at night during clubbing and dancing, there's very little appreciation that they will become addicted to nicotine for the rest of their lives. I've spoken with many college girls, and no one ever mentions nicotine addiction. So we now have approximately 24 million Americans smoking, an estimated 12 million worldwide, and if the current patterns continue by 2025, approximately there'll be 5 million women smoking worldwide. And if you look at the global death rates, the United States has the highest global death rate for lung cancer, followed by Denmark, Canada, United Kingdom, and New Zealand. And if you put all the cancers in women together, the leading cancers causing death, it still does not equal the amount of lung cancer deaths in women. And if you ask women what is the leading cause of cancer death in the United States, 95% of them will say breast cancer. Lung cancer is very little known among women as a major cause of death among them. And while there's still a higher death rate among men, if the present trends continue, and this is the trend in smoking over the past several decades, there's been a marked decrease in men smoking. This came after the original Surgeon General's report of smoking associated with cancer, but a much less decrease in women's smoking habits. And actually, in the last decade, there may be, again, a small rise in the incidence of smoking among women. So as I said, if these continue, these cancer incidences will begin to come together and even cross if this increase in smoking among women continues. And this is just a pictorial rate of the increase in cancer death rates among women up to 2000, and they have become more steady since then. I'm going to skip this and just say that we are now exporting our cancer to third world countries, and with the tremendous impetus of tobacco advertising, there's been a significant increase of smoking among women in Africa and Asia. 20 million women started smoking in China in the 1990s, and the prevalence of smoking among Japanese women has increased has doubled actually from 1986 to 1991. So we're in the middle of a global epidemic, and tobacco use is the most preventable cause of disease in the world. And if you think about it, it's really the only legal product that kills prematurely half of the people that use this product. And the tobacco industry has a daunting task. They have to replace the 500,000 people that die each year of a smoking-related illness, and they do it quite well. So I want to just go through the differences between men and women with relation to lung cancer. This is a now famous study done by Zhang and Widner looking at a potential genetic difference in the relative rate of lung cancer. It was a hospital-based case control study looking at about 2,000 men and women, a little bit more men than women, and 2,000 controls. And what they found was that women were more likely to be never smokers. Among smokers, men started earlier and smoked more. The dose-response ratio was 1.2 to 1.7 higher in women than men, and even adjusted for height, weight, and body mass, women being smaller, these odds ratios did not change. The conclusion was that women were more susceptible to the effects of tobacco carcinogens than men, that women were more likely to be non-smokers compared to men, and women with lung cancer smoked less than men. And there have been now many studies that showed the same. These were mostly case controls. Many of them had lots of patients, and many of them showed the same thing, an increased odds ratio in women who smoked compared to men. However, there's an equal number of studies, and these are mostly cohort studies, with again large numbers of patients showing no difference in susceptibility of women smokers to men to develop lung cancer. It's very hard to interpret these studies because, for the most part, these are self-reported. You really don't know how the women and the men are smoking, how many puffs they're taking on the cigarette, how deep the inhalation is, and what type of cigarettes they're smoking, whether they're smoking filtered cigarettes or non-filtered cigarettes. But the final conclusion after experts looked at all these studies was that it did not appear that the evidence supports the hypothesis that women are more susceptible to smoking-induced lung cancer. But a larger question is whether there is a potential sex difference in the etiology of lung cancer, because many, many studies now show that if you are a non-smoker and you have lung cancer, you're much more likely to be a woman than a man. In fact, some of the studies show an increase of 200%. So why is that? And that's where the conflicting data comes in and the controversy comes in. But if you look at non-smokers in the United States, there are about twice as many women with lung cancer who don't smoke than men. And globally, this difference is markedly increased. Globally, there are 16% of men who have lung cancer that don't smoke, but 46% of women who have lung cancer do not smoke. The reason for this is unclear, but there may be environmental reasons. Particularly, attention has been drawn to the biofuels that women use, particularly in low economic countries where they cook with these biofuels in very poor ventilated areas. So if you look at the molecular difference, this is very interesting. And I'm going to use tobacco because it's the most studied, and it looks at how women can metabolize the carcinogens in tobacco smoke. There are 4,000 chemicals at least in tobacco smoke. These include formaldehyde, arsenic, cyanide, and at least 60%, these are not even the carcinogens, 60% are carcinogens. And if you look at how these are metabolized, these carcinogens, putting it very simply, it's much more complicated, but two things can basically happen. You can detoxify them and get rid of them in the urine, or you can hold on to them, and by this cytochrome enzyme system, the P450, which includes the CYP1A enzyme, these can be metabolically become active and bind to DNA adducts. DNA adducts are basically abnormal DNA. And these adducts can either be repaired by DNA repairing capacity, or they can undergo apoptosis, or they can persist and then change into mutations or develop mutations that are associated with lung cancer. What has been found is that women have higher DNA levels whether or not they have lung cancer and whether or not they smoke. And the conclusion is that women have higher abnormal DNAs than men, whatever the reason. And if I'm sure we're all exposed to carcinogens, whether it is in tobacco smoke or not. And the DNA adducts have been found in target tissues, particularly in lung tumors, and they are thought to play a role in the initiation of carcinogenesis. Women have been found, as I said, to have more DNA adducts. They have less DNA repair capacity. So this may be one of the explanations why women may have a higher risk of developing lung cancer. If you look at the genetic causes, there's a very interesting study that is not well known, and I have never heard anybody quote it, but I think it's a very interesting study. It looked at something called the gastrin-releasing peptide. This is a peptide with this receptor that is part of the bombesin family of carcinogens or mutagens. And this works by stimulating cell proliferation. It's important because the gene for this GRP receptor is X-linked, and it is near a cluster of genes that escape X inactivation. Therefore, women can have two of these active genes. So there was a doctor called Sreedhar who explored this sex difference, genetic difference between men and women, and she looked at this GRPR expression in lung tissue and cultured cells from 78 subjects. 40 were women, 48 were men, 48 women. She found something very interesting, that this gene was expressed in 55% of non-smoking women compared to 0% of non-smoking men, and 75% of smoking women compared to 20% of smoking men. And these were generally light smokers. She considered less than 25 pack years light smoking. And she concluded that this may be the explanation why women have an increased risk of lung cancer, because they have two copies of this gene, either without smoking chronically, or it can be induced by nicotine. And as I said, this gene has been associated with carcinogenesis. She also found that when airway cells were exposed to estrogen, there was an increased expression of this gene, suggesting that it may be regulated by estrogen. And that brings us to the next topic of hormonal regulation. And again, the data here is confusing and very controversial. But estrogen is mediated by alpha and beta receptors in normal cells, and these have also been found in tumor cells. The mechanism by which estrogen is involved is unclear, but there's several theories. It can activate metabolizing enzymes to form DNA. Looking at the other slide, it can play a role in the cytochrome system by causing these carcinogens to become more active. It can act directly on carcinogens via the formation of DNA adducts, which is abnormal DNA basically. They've been shown to play a role in several growth factors, transforming growth factor and the EGF epidermal growth factor receptor, which play a role in cell division, and they also can stimulate angiogenesis. So several studies have shown that estrogen or combined estrogen and progesterone may be associated with lung cancer. The first study was from China that showed there was an increased lung risk in women with shorter menstrual cycles, i.e. More estrogen influence on their lives. The second one was done by Tioli and Widner, the same gentleman who did the original epidemiologic study with Zhang. And this was a small hospital-based study which looked at women who had lung cancer versus women who did not. What they found was there was an early age, 40 or younger, associated with a reduced risk of adenocarcinoma, hence less hormonal effects on the body. Estrogen therapy was associated with a higher risk of adenocarcinoma, and there was a statistically significant synergism between smoking and hormonal replacement. The odds ratio for developing lung cancer for smokers without HRT was 13 versus 34 for smokers on hormonal replacement therapy. Now, these studies, let me go back. There's many other studies that show opposing results. Some show there was a decreased risk in lung cancer in patients on oral contraceptives. Some showed there was an increased risk in patients on estrogen replacement therapy. So very confusing. This was a study that showed that the risk was greater if you were older and less if you were younger, if you took hormonal therapy. So the studies are all flawed by lack of information on the type of hormonal replacement, whether it was estrogen alone, progesterone and estrogen, the duration of the hormonal therapy, age differences, the timing of the use, and there was very variable follow-up. There was the probably best study till now, which was the Women's Health Initiative study that looked at the effects of hormonal replacement on the lives of women, comorbidities in women. And we're all familiar with this study.